Toda, Dr. Hartman. That's my only word in Hebrew. Toda. When I got to Israel, I realized I'd forgotten my tie, but I knew I could borrow one from Yoram. But then I saw his tie, and I thought maybe I won't do that. And then I decided it's okay, I'm in Israel. Okay. This talk is going to build on what Dr. Hartman said, because I have been involved for the last 15 years in treatment of victims of medical child abuse. And my wife, Dr. Jenny, and I have published a book about this called Medical Child Abuse Beyond Munchausen Syndrome by Proxy. Our interest in this type of child maltreatment dates back about 20 years now, when we were both working in Denver. I was at the National Jewish Center in Denver, treating asthma and immunologic diseases from a psychiatric standpoint, and Carol was at the Denver Children's Hospital. And an 18-month-old boy who was treated at our hospital presented with progressive respiratory symptoms, not unlike the blue spells that Dr. Hartman's baby was experiencing, but these all happened in the hospital, in the hospital environment. The child would be well, usually in his mother's arms, and then he would suddenly get sick and have respiratory difficulties and would either recover briefly after a few minutes or a few hours, or in some cases ended up on a respirator. All of these events took place in the presence of his mother. One of our very respected respiratory physicians went through a chart which was this thick and documented that all of these events took place in the presence of the mother. And when we talked with her about this and said that we were removing the child from, or removing her from the hospital so she couldn't harm her child anymore, we discovered that what she was doing was giving him a drink of Coca-Cola and then covering his mouth, and he would then breathe the Coca-Cola and have a respiratory pneumonia, or an aspiration pneumonia. When we went to talk to the prosecuting attorney, Dr. Jenny and I said, this mother almost killed her child. This is attempted murder. And he said, oh, I thought this was a Munchausen by proxy case. And that set us to thinking that maybe we have things backwards. We should not be focusing on the mother, we should be focusing on the child. That it's not what the mother does, it's what happens to the child that's the most important and the most significant feature. We can go back to the mother later, but first we need to focus on the child. I have been working for the last 15 years at a day treatment program in Providence, Rhode Island, where we treat children who are medically ill and also psychiatrically ill. We treat children with diabetes, with ulcerative colitis, with many, many illnesses, but among these children are some whose illnesses are totally unexplained by the history that we get or the medical evidence that we have. And these are the children. It's a small proportion of the children we treat, but these are the ones who have developed our interest in treatment of medical child abuse. The program we have keeps kids 8 hours a day, 5 days a week. There are younger children in one group, older children in another. They stay 16 days. We have about 160 admissions a year. So this is an ideal environment for us to collect and study those children who fall between psychiatric diagnoses and medical diagnoses. This slide, what's in a name? These are some of the names given to this particular type of child maltreatment. Munchausen syndrome by proxy, Munchausen's by proxy syndrome. That's, in some people's definition, supposed to be different. I'm not sure why. Factitious disorder by proxy, pediatric condition falsification, fabricated or induced illness in a child by a carer. There's a new paper just out by the American Academy of Pediatrics that goes back to this use of fabrication. What these names all have in common is they're all talking about lying. They're all talking about lying. However, lying is not the important feature of this type of child maltreatment. All parents who maltreat their children lie. They lie about sexual abuse, they lie about physical abuse, they lie about neglect. What's really different about this type of maltreatment is that the maltreatment occurs within the medical environment. We define medical child abuse as a child experiencing unnecessary and harmful or potentially harmful medical care at the instigation of a caretaker. A caretaker is making it happen. Once again, the distinctive feature is not that a caretaker is doing it, because most child maltreatment is caused by caretakers, nor is it have a lot to do about lying, because most caretakers who maltreat their children lie. The salient feature is the medical care community. It's us. It's those of us in the medical environment. Now, the pediatricians who we talk to about this get very upset because they think we're saying that pediatricians are doing bad things to children. And if we say medical neglect, they don't think, oh, doctors are neglecting children. They know that that's parents. But if we say medical abuse, they think we're accusing them of something, right, Gershon? And we run into this all the time. Actually, the pediatricians are more sensitive to the term than are the social workers or the prosecutors. They're not as sensitive, and I'll get to that in just a minute. We have a word for when doctors actually cause harm to, when they instigate, when they start maltreatment of children. We call it malpractice. That's harmful medical care instigated by the doctor that does not meet the community standard of care. Medical child abuse has many features in common with other forms of child abuse and only a few differences. How is it like other forms of child abuse? Well, it presents in many different ways. You heard about Dr. Hartman's case today with smothering, and she described exaggerating symptoms or fabricating symptoms. The severity of the abuse ranges from mild to severe. Usually we only hear about in the newspapers the most severe cases. But every pediatrician that I know has parents who exaggerate symptoms to the extent that their children might get unnecessary care. That might be a mild version of this presentation. But physical abuse, psychological abuse, sexual abuse, they all exist on a continuum from mild to severe. And at a certain point along that continuum, there is a threshold, a line that the community, not the medical community, but the community at large says, this is too much. This is when we stop calling it bad parenting and start calling it abuse. And that threshold exists for each type of child maltreatment, and it exists for medical child abuse as well. Medical child abuse is not an illness, neither is sexual abuse an illness. It's a bad thing that happens in the life of a child that can result in illness, either psychological illness or physical illness. How is medical child abuse different from other abuse? I've already said the medical care system is the instrument of the abuse. We, unwittingly, without wanting to, have become the means by which a parent is able to do harm to her child. If you compare perpetrators of medical child abuse with other kinds of child abusers, pretty much universally they have unfortunate childhoods, they have sad childhoods. All perpetrators lie. They resist treatment unless they're compelled by others, by our social service departments or the police. The case that Dr. Hartman presented, the mother eventually acknowledged that she needed help and was able to allow treatment, but only after she was put in a position where that was necessary for her to do so. This is totally consistent with perpetrators of any other form of abuse as well, as many of you in the audience can, I'm sure, confirm. The perpetrators of the abuse can have many different motivations. If you ask the perpetrator of sexual abuse, why did you sexually abuse that child? And I'm sure there are people in the audience who've asked that question. The answers are widely variable. They may be, oh, I thought I was giving my child sex education, or the motivations are all over the map. And the same is true for medical child abuse. The one difference between these forms, this form of perpetrator, is that 95% of them are women, just like 95% of men are the ones who commit sexual abuse. So why have we spent all this time talking about falsification and the Baron von Munchausen and lying that took place in the 17th century? Because doctors and the medical personnel are the instrument of the abuse. We find a need to explain how we got involved in doing exactly what we don't want to do. We exist to help children, and now we are being put in a position where we're not helping children, where we're causing harm to them. So we, instead of saying, whoa, stop, let's stop doing this, let's give this child the right treatment, we spend a little extra time explaining ourselves and focusing on the why, to the detriment of understanding what happened and how we can stop it. I believe, and a lot of other people are coming to believe around the United States anyway, that medical child abuse is a result of a breakdown in the doctor-patient relationship. When a patient goes to the doctor, there's a certain set of rules that govern how that relationship will be conducted. And in this particular instance, a parent is breaking the rules. They're not allowing the doctor-patient relationship to function in the benefit of the child. Here are some of the rules for being a good patient. You admit you're sick and that you need help. This is really bad for me. I never could admit that I'm sick, and my wife has to say, no, you have to stay home. With this admission, when you admit that you're sick, you get permission to stay home or from work or from school, but in exchange for that privilege, you agree to cooperate in good faith with getting well, in re-entering the community of your peers and your colleagues. You promise to return to normal activities as soon as the illness is over. That's the price you pay for getting a few days off from work. So, in agreeing to cooperate with treatment, you also agree to provide honest, accurate information to treatment providers, because treatment based on false information is seldom appropriate or helpful. This concept that we need to be honest with our doctors is so important that it has been with us for 2,000 years in the practice of medicine. We provide confidentiality to our patients. We won't tell anybody what you tell us, in exchange for the fact you have to tell us the truth. And this is even put in the legal system, that doctors need to know the truth. So it's so important that we have this level of confidentiality that is built into the entire medical care delivery system. So what happens when people don't tell the truth, when they don't follow the rules? We all assume that our parents are following the rules, and sometimes we assume too much. What about lying? This is just to remind people that people lie to their doctors about lots of things. They lie to them to get drugs. They lie to them to get away from work. They lie to them when they go and say, well, I'm really following your diet, doctor. I don't know why I keep gaining weight. Geriatricians, people treating older people, and psychiatrists are not always as trusting of their patients, but pediatricians are such nice people. They believe everything that's told to them. And this has been one of the things that's gotten us in trouble. I'm going to give you a little bit of data from 115 cases that were referred to our child protection program at Hasbro Children's Hospital and treated in the Hasbro Partial Hospital program I was talking about a little bit ago. The inclusion criteria for these 115 cases is that someone who sent the child to us referred to it as a possible case of Munchausen syndrome by proxy. Somebody was worried that this was a Munchausen case. That's all it took to get into our study. This was a retrospective chart review study. We also had to have sufficient medical records to make a determination of unnecessary or harmful or potentially harmful medical care. We had to have good medical records. And we examined the records to determine the illnesses or symptoms that were claimed by the mother. Then we organized them by organ system, all the respiratory symptoms in one pile, all of the stomach, gastrointestinal symptoms in another pile. We compared the symptom claims, what the mother said, the history, with the objective evidence that came from medical testing, from laboratory studies, from physical exam, and we documented the care that was received that was not based on objective medical evidence. We documented parental acts that led to the unnecessary medical care. We looked for specific things the parent did. Did the parent put dye in the urine, for example? That would be an example of a parental act. So this, this is not going to be readable. I'm sorry about that. I'm missing a piece of this. These are by organ system, and I'm just going to have to kind of tell you. These are GI and neurology and allergy, the organ systems that are most based on parent report. And right along the bottom here, that's what this says, but you can't read it because of the way the slide got translated. Over here, this is psychiatry. Now, many of these patients were in my psychiatric day treatment program. The green represents, these are confirmed symptoms. These are symptoms that are confirmed by history, by laboratory testing. The yellow represents, well, maybe we might think that they're confirmed. And the red, there's no evidence whatsoever that the symptoms can be justified by the objective evidence. So if you just take this, for example, about 3/4 of the symptoms in our study population there was no objective evidence for the claims made by the parent. I'm sorry that slide wasn't more illustrative. 87 of the 115 children we determined to meet the criteria of medical child abuse, about 75%. Remember, that means that they had unnecessary and harmful or potentially harmful medical care instigated by the caretaker. 1/4 of the people referred to us didn't meet that criteria, even though they had been referred to us as either cases of or possible cases of Munchausen syndrome by proxy. 26% of the children had no illnesses that we could ever document, but 74% received care far in excess of the care required by objective evidence. Most of the children we saw had an underlying illness, which was then being treated much more aggressively than necessary. They had an illness which then had been exaggerated or supplemented by parents. What types of unnecessary care did we see? Of those 87 who met our criteria, 81 had unnecessary medical visits. Now, I want you to look as we go down the list, the numbers are getting smaller, and the interventions are getting more intrusive. An unnecessary medical visit may not be such a bad thing for a child to have, an extra trip to the doctor. Even 10 extra trips to the doctor might not hurt him. But if the child is receiving unnecessary medications, as 74 of our kids did, that might carry some potential harm. How about unnecessary invasive tests? These are blood draws or colonoscopies. Unnecessary minor surgery would be cut downs, getting center ports put in. Unnecessary major surgery, children who received Nissen fundoplication surgeries, which was our most common unnecessary surgery, by the way. Remember, the GI people come out on top. I'm now going to shift to talk about treatment. So what I've just been talking about is, I hope, building on what Dr. Hartman said, but now we're going to talk about what do you do about it. And it turns out that she and her team did a very nice job with the case that she was talking about. These are the steps in treatment, I believe, in all forms of child abuse. I try to make things simple. This is I teach my students with this slide. First, you have to identify it. Second, you stop it. Third, you make sure it doesn't come back. You provide for ongoing safety. 4, you repair the damage caused by the abuse, the physical and psychological damage. And the 5th step in treatment is to have all of this treatment occur in a way that best preserves the family. All right? So in each of these, you can think for a minute about what you do in your daily work. Identifying abuse can take weeks to months to years in some cases, and that's the same is true for medical child abuse. Stopping it is the first thing on our agenda once we've identified it. Providing for ongoing safety. You can see how this would apply to all forms of child maltreatment. But with medical child abuse, there are specific, I think, things that we have not taken into consideration until more recently about what we need to do. The first crisis, if we go back to identifying it, the first obstacle or crisis in treatment of medical child abuse is what we call the "oh my God" crisis. This is when we kind of wake up to the idea that something bad has been happening in our institution, that we've been providing care that this child didn't need. And then the medical team and the social service unit and all the people involved in this child's care start to talk to one another, and they start second-guessing. What happened? Did I miss it? I can't believe it. I'll bet Mom has that Munchausen thing. These are the kinds of things that people start to talk about during that first phase of identifying it. What makes it easier to identify medical child abuse is to, first of all, think that it might be happening. Again, Dr. Hartman said she was off on maternity leave. I don't know why she went off on maternity leave. She should have been working all that time. But other people didn't think it might be happening. If she were there, they might have thought about it earlier. You need to practice good evidence-based medicine. You need to do that history, do the complete physical. Don't just take the mother's word for it. Listen to the mother. Obviously, listen to the mother, and then compare what the mother says, just as you would with other forms of child maltreatment. My baby rolled off the bed and had a tremendous head injury. Dr. Jenny told us this morning, that's not likely to happen. So the same thing might be happening if a mother says, my child had 17 seizures, and nobody saw them. That might be something we might want to take into consideration. as physicians and as medical care providers and as even social service providers, we can't just be empathic. We also have to have a little bit of skepticism. We have to ask the right questions. The question is not, does the mother fit the profile for Munchausen syndrome by proxy? The question is the child being hurt by unnecessary care resulting from the violation of the basic medical treatment contract? That's the question we need to ask. Once we've asked that question and answered it in the affirmative, once we say yes to that question, we've identified medical child abuse. So how do we resolve this crisis? I feel that over the years, in the people we've been working with, our threshold has gone way down. We suspect people much earlier, and many times we're wrong, but that's okay, because if we suspect that we might be getting false information when the child is getting his first dose of anti-seizure medications that he doesn't need, then maybe we can spare that child from having 3 more courses of anti-seizure medication. If we have a low threshold before the damage is done, we can spare the child from unnecessary harm and perhaps even morbidity. And it allows us to work with the family at a lower level of intensity before the case gets in the news media and people are putting it on the TV. We can talk with the family and reestablish a workable doctor-patient relationship. So this is for those people who do this at a very high level. How do you do an expert evaluation? You get all the medical records, you make a table with every medical event in the child's life, you look for patterns, and you cite evidence for a child receiving unnecessary, harmful, or potentially harmful medical care. This is the job that we end up doing when we are dealing with those extreme cases, the ones way out at the extreme end. This is actually not even a very big case in some of our experience. We've had cases where I had one case where I had 30,000 pages of medical documentation to go through. This is an example of the table I talked about. This particular child had multiple surgeries for granuloma annularum, which is a benign skin condition. But the mother told one doctor that she had a relative who died of this condition. That's not only an exaggeration, I think that's a falsification in terms of your continuum of severity of parental acts. And when you do a table like this, things jump out at you. In one of our tables, the orthopedist note for that particular day on, say, the 9/15/1989, the orthopedist note said, condition resolved, no further treatment necessary. The next note was a call from the mother to the pediatrician saying, the orthopedic doctor says he's going to have to amputate the leg below the ankle, below the knee. Now that's a pretty big discrepancy, and when you put those 2 pieces of medical evidence against one another, you think this child really is in very high danger of being medically abused. Okay, step number 2, after you identify abuse, the next step is to stop it. So how do we do that? And this crisis in medical environments which are dealing with these cases for the first time or early on, the medical team seems flabbergasted about what to do. Obviously, what needs to happen is the medical treatment the child is receiving should be stopped. That's what stopping medical abuse consists of. But we find people saying, should we send the mother for a psychological evaluation? Should we call? Do you have risk management in Israel? Yes, you know what risk management? Should we call the lawyers for the hospital? Should we call a Munchausen syndrome by proxy expert? What about the police? Actually, what needs to happen is you have to stop the medical treatment. And to do that, however, and this is one of the hardest parts of treating medical child abuse, is you have to get all the doctors to agree. Now, I don't know how many of you know this, but doctors sometimes think they're very special. They think that they have all of the answers. And two of them together might have different sets of answers, but they each think they're right. So getting all of the doctors to agree that this child has been receiving unnecessary care is sometimes very difficult to do. You have to get them in the room and say, what's your evidence that this child is having seizures? What's your evidence that this child was blue? And when you do that, then you can have the doctors come to a consensus that the child is receiving unnecessary care. And then we can move on to the next step, which, again, Dr. Hartman described to me. I can't remember whether she told you. The next step is to go to the parents and have what we call an informing session. It goes like this. Mrs. What's a good Israeli name? Mrs. Cohen. We have very good news for you. Your child is not sick. Isn't that wonderful news? And her husband is sitting there, and maybe her rabbi is there with her, and maybe her aunt Sophie is there with her. And we have wonderful news for you. Your child is not sick. We thought she was sick, but we have good news. She's not sick. Or she's only a little bit sick, and we're going to take away all of these medical care, all these medical symptoms, and we want you to help us make sure she does not get any more unnecessary care. How do you like that, Mrs. Cohen? And if Mrs. Cohen says, oh, thank God, my child's not sick, that's good. But if Mrs. Cohen says, you're stupid, you're an awful doctor, I'm going to go to Tel Aviv and get the real doctors to find out what's wrong with my child. Now we are in trouble, right? Now we have a mother who is not willing to renegotiate the doctor-patient relationship with us. In Dr. Hartman's case, when they told her that they didn't believe their child was having seizures, she eventually said, "Oh yeah, I think I may have made it up." Right? She said something on that. She took responsibility for her part in distorting the doctor-patient relationship. A child protection team, the multidisciplinary team, is very important because these cases just make it very difficult. If all the people don't participate together, agree with one another, step by step along the way, then things can very quickly go bad and fall apart. Social services needs to be involved. The doctors have to agree. You have to be ready for a range of responses, and if you get a good response, great, we move ahead. If we get a bad response, we may have to start thinking about whether or not this child can stay safely in that family environment. The child protection team is absolutely necessary. I know one of your people today was talking about all of the different components of the child protection team. In the U.S. now, we're telling people, don't use the term Munchausen syndrome by proxy. If you do that, people will say, isn't that rare? Isn't that unusual? Isn't that where the mother is weirdly getting her own needs met? And all of that just distracts from the fact that the child is being hurt. We say, call it child abuse. Be specific about what happened to the child. Be specific about what surgery the child received that he didn't need. Be specific about what the mother did to get the surgery that the child didn't need. But don't put a psychiatric label on it. Just call it abuse. You're going to want to get a psychological evaluation of the mother eventually, but not now. What you want to do now is stop the abuse. The crisis number 3 is preventing abuse from reoccurring. And this is in the US, we sometimes have child protection services who say, well, doctor, this is your problem. You know, just don't give the medical treatment. And we say, we tried that. We're trying to stop the medical treatment, but the mother is going to take this child to another doctor. We need your help. We need you to go to the mother and say, along with us, this is bad for your child, and if you don't stop it, we're going to take your child away. We need your help. And that's what this third stage of treatment, maintaining that the child will not be abused again. It's not enough just to stop it. We have to stop it permanently. Call it child abuse. Write really clear reports. What happened to the child? How did it happen? Where? When? And really work together as a social service medical team. We have child protective investigators in our country. You have those here too, people who go and investigate whether abuse has happened in the family? Yes? Okay. The questions that child protection team person must ask is not, did you follow the doctor's orders, because the mother will always say yes. What you need to ask is, now that the doctors have determined that your child got care that he or she did not need, are you willing to cooperate with them? Can you acknowledge that maybe you did something that got the doctors to give treatment that they shouldn't have given your child? Can you work with the doctors from now on? Don't ask if she wants to have her doctor be nice to her. Just ask if she's willing to help maintain the safety of her child. And if she says no, or if she gives answers that indicate no, then that means that we really need a higher level of intervention. We use what we call contracting. After we've talked to the mother and we've got all the doctors to agree that what the new medical treatment is going to be, we write it down on paper. Sometimes we'd like to keep it to one sheet of paper, but sometimes we go into great detail because sometimes these contracts become part of a legal step down the road. And we say everything that happened to the child and what we expect the parent to do from now on. We put it in writing. We take the doctor-patient relationship, which largely prior to this was unspoken. It was it was just custom. It was tradition. And now we write it down on a piece of paper and saying, no longer are we going to rely on tradition. This is what we expect of you, and this is what you can expect of us. We will always listen to you if you have a complaint about your child's health. However, we're not going to necessarily give the treatment you recommend, because we're only going to give treatments based on what the signs and symptoms of medical illness a child presents with would warrant. Do you agree with this? Will you sign here? If the mother signs, her husband signs, the Rebbe signs, and then we sign as well. And the more people you get involved, by the way, the easier it is. The easier it is to have the contract be. And then we take the contract and we send it to, some of our patients have 17 different doctors. And we send the contract to all of them. And we put it in the emergency room of the hospital. And we put it in the medical record. So, because what we want everybody to know is that no longer do we want this child to get medical care that was harmful or potentially harmful and unnecessary. And with this written record now, everybody is on notice. Stage 4, repairing the damage. The child is our primary concern. Yes, we're concerned about the mother, yes, but we want to really help the child first. And the way you do this is by stopping the medical care, and you want to stop the most lethal medical care first. If a child has a central line, a cannula going into the inferior vena cava, you want to take that out because it can get infected. If the child is on anti-cancer medication that she doesn't need, you want to stop anti-cancer medication. or anti-seizure medication. You take the most serious treatments and reverse them. If the child's had surgery and has a colostomy that they don't need, you want to reverse the colostomy. You want to take rid of the most lethal treatments first. And we also want to think about psychological trauma. The psychological trauma that comes from this type of child abuse is actually comparable to traumas experienced in other kinds of child abuse. Yes, there's the physical trauma, but the psychological trauma basically is based on loss of trust. The people who were supposed to be taking care of you, nurturing you, keeping you safe, giving you love and protection, they let you down. And that is experienced in a fairly predictable way between victims of medical abuse, psychological abuse, physical abuse, sexual abuse. There have been very few studies about the long-term effects of medical abuse. The ones we do have show that people have lost faith in the medical profession. They have a tendency to have higher anxiety disorder rates, higher depression rates, and PTSD and post-traumatic stress disorder, the same kinds of illnesses we see in other kinds of children. Okay, the fifth step, preserving the family. Most children in our experience end up staying with their family, but now's the time for the psychological evaluation of the mother. Now's the time for her to get into treatment and to start dealing with what it was that made her expose her child to this type of child maltreatment. We've found that different kinds of treatment have been effective for mothers in these situations: individual psychotherapy, cognitive behavioral therapy, DBT, motivational interviewing, family therapy. Most of our families start with family therapy because we really want to stay with the unit that the child already has in his or her life. And we want to build on it. We want to enhance the strengths of that family unit. And sometimes you find things where parents, the father says, well, my wife has always taken the kid to the doctor, but I think that maybe we should change that now. Don't you think, doctor? Yes, I think that might be a good idea. Maybe you should go along with your wife every time the child goes to the doctor. Maybe the mother-in-law is willing to step in and help develop a new attitude toward the medical profession. We also use community resources. We use, you talked about calling the school and asking if the child had seizures in the school. We talk to the schools and say, if this child misses a day of school for any reason, it's in her medical contract that you can call the pediatrician and say, what's wrong with this child? Do you see how that medical contract now extends in a larger area? What about teenagers? We have experience with older children, 9, 10, 12, 14, who have been medicalized. They've been treated as if they're medically disabled all of their lives, and now they use these medical symptoms for their own benefit, to get out of school, to not to do work around the house. If they've learned to respond to normal life stresses by pretending to be ill or making up some illness, that's understandable if they've lived in that environment for their entire lives, but it's not very functional. And our job is to work with the family to, once again, we call it rebooting. We're going to start over again, and we're going to set up a new set of criteria for how medical symptoms are going to be treated in your family. So here's the spectrum of treatments from least to most intrusive that we would. This is the last slide. Counseling in an office setting. Pediatricians do this all the time. Refer a parent for therapy if she's an anxious mother or depressed. Get family counseling. Involve outside agencies to monitor care. Send the child to a partial hospital program like mine, or send the child in the hospital to see if the symptoms stop when separated from the parents. report to Child Protective Services, remove the child from the parent, and the last, and very, very rarely, is there prosecution of a parent or incarceration. Summary slide. Don't always believe caretakers. Call it abuse. Get all the doctors to agree with one another. Make the doctor-patient relationship explicit. Treat the child, worry about the parent later. Maintain good relationships with social services and the lawyers and the prosecutors. Support the family, but don't sacrifice the child. That's my talk. Thank you.